Welcome everyone. In this lecture, we will be discussing the pharmacological treatment for gout. Despite predominantly being a joint disease, gout is classified as a metabolic disorder. And the reason behind that is that gout is associated with an abnormally elevated levels of uric acid in the blood, which we call hyperuricemia. Gout is the most common crystal-induced arthropathy caused by monosodium urate crystals deposition in joints. Elevated serum uric acid levels are the principal risk factor for developing gout. So how do we know that? How are we sure that hyperuricemia is very important? In the early studies, it was found that when you compare patients with asymptomatic hyperuricemia with normal uricemic patients, the odd ratio for developing gout was 32 times higher in patients with hyperuricemia in comparison to those with normal uric acid levels. The risk, of course, was most pronounced in men with severe hyperuricemia, in whom the odd ratio becomes really high. This means that men are more susceptible for developing gout if they had hyperuricemia. Of course, hyperuricemia does not always lead to gout. However, gout must always be preceded by hyperuricemia. This means that not all people who have hyperuricemia will develop gout, and that also means that not all people with hyperuricemia will require uric acid lowering therapy. Gout is not basically triggered by a particular level of uric acid. It's more triggered by the acute fluctuations in uric acid levels in the blood. That's why some patients would have high levels of uric acid for a long period of time without actually having an acute bout of gout. Gout may be either primary or secondary. Primary gout is related to the undersecretion or overproduction of uric acid, often associated with a mix of dietary excesses or even excessive alcohol consumption. Secondary gout, on the other hand, is related to medications or conditions that can cause hyperuricemia. Most cases of gout are considered primary. So let's take a look back at the biochemistry of uric acid. Remember that uric acid is the end-stage byproduct of purine metabolism. It is produced here in the last step of purine metabolism when xanthine is converted into uric acid by the enzyme xanthine oxidase. So this is the critical step that converts xanthine to uric acid. Uric acid is then eliminated through renal excretion. So how can you get elevated levels of uric acid in the blood? There are actually two main ways of how hyperuricemia can develop. In about 90% of patients with gout, hyperuricemia develops because of an inability to excrete sufficient amounts of uric acid in the urine, which we call under excretion of uric acid. So this accounts for the majority of cases of hyperuricemia. Most of the remaining patients either overconsume purines because purines are found in certain food types. Some food types are rich in purines, and consumption of excessive amounts of purine-rich diets can cause hyperuricemia, or those patients can produce excessive amounts of uric acid endogenously, which we call overproduction. However, this accounts for a small minority of the cases of hyperuricemia and usually occur in the context of rare genetic disorders. Finally, a few patients will develop hyperuricemia because they have impaired intestinal elimination of uric acid, because uric acid can also be eliminated by the gut. But always remember that uric acid is primarily excreted through the kidney, and when excretion is insufficient to maintain serum urate levels below the saturation level of uric acid, which is 6.8 milligrams per deciliter, then uric acid will become saturated in the plasma and urate will start to deposit and precipitate in soft tissues. So what happens after hyperuricemia is established? When tissues become supersaturated, the urate salts start precipitating, forming crystals. In addition, the crystals also are less soluble under acidic conditions and at low temperatures, such as in the cool peripheral joints, and that actually explains why the classical presentation of gout involves the metatarsophalangeal joint of the big toe. Urate initially precipitates in the form of needle-like crystals. The deposition of urate crystals then initiates an inflammatory process involving the infiltration of granulocytes that phagocytize the urate crystals. Because these urate crystals depositing in the synovial space are considered foreign bodies to the circulating leukocytes. So they start the process of migration from the plasma and they start engulfing and phagocytizing urate crystals. And that initiates an acute inflammatory process, which usually is the reason that result in the flare-ups of gouts that clinically present as pain, swelling, tenderness, and redness of the affected joint. And that explains why most therapeutic strategies for gout involve lowering the uric acid level below the saturation point, which we said it's 6.8 milligrams per deciliter. And that's the approach number one, because that will result in the prevention of uric acid and deposition and uric acid crystal formation in the joints. But at the same time, this is preferably should be accompanied by treatments that will reduce the inflammatory process that result from the deposition of uric acid crystals in the joint. Just quickly, let's go over some of the secondary causes of gout, and these include excessive alcohol consumption or the excessive consumption of purine-rich diets. Other causes that can result in secondary gout are chronic kidney disease that results in a poor excretion of uric acid, or cases of severe starvation or dehydration. Remember that there is a variety of drugs that can also result in an increased uric acid serum levels, and these drugs should be avoided in gout patients. Probably you can remember the drug niacin, the anti-hyperlipidemic drug that is known to increase uric acid levels in the plasma, excessive alcohol consumption, as we've said, and more importantly, salicylates such as aspirin also interfere with the excretion of uric acid in the kidneys and thus results in hyperuricemia. And these should be also avoided in patients with gout. So what are the main approaches that are required for the management of gout? First of all, when a gout attack happens, as we said, presents with extremely painful joints, redness, swelling, the aim is to treat the acute attack and relieve the symptoms. And that approach heavily relies on the use of anti-inflammatory drugs because, as we mentioned, the acute attacks of gout are caused by an acute inflammatory response. In addition to treating the acute attack, we can use prophylactic therapy to prevent those acute attacks before they happen. And chronically, we'll need to lower the excess levels of uric acid in plasma to prevent uh, recurrent bouts of gout on the long term. So let's talk about the treatment of acute gout. Remember, there is always a temptation for physicians to actually treat hyperuricemia without a proven diagnosis of gout, and that should actually be avoided. Remember that not all patients with hyperuricemia will eventually develop gout. Treatment of acute gout should involve patients who only those that develop acute symptoms and signs of gout. Remember also that one of the important differential diagnoses of acute gout is septic arthritis, which is the inflammation of joints caused by bacterial infection, and that disorder may clinically resemble gout or pseudo-gout, and in case it was unrecognized or mistakenly diagnosed as gout, can result in the loss of life or a limb. Distinguishing septic arthritis from crystal-induced arthritis is not possible without an examination of joint fluid, which means that patients with a classical presentation of gout should have a biopsy of their joint fluid taken where the uric acid crystals can be visualized using microscopy. Acute treatment of proven crystal-induced arthritis is directed at the relief of the pain and inflammation. So remember, acute gout is an inflammatory disorder, and that's why the treatment of it is basically to relieve pain and inflammation using anti-inflammatory drugs, such as primarily non-steroidal anti-inflammatory drugs, in addition to corticosteroids, colchicine, adrenocorticotropic hormone, and anakinra. Notice here that uric acid lowering therapies are not beneficial for the treatment of gout. In fact, therapy to control the underlying hyperuricemia generally is contraindicated until the acute attack is controlled. Starting therapy to control hyperuricemia during an acute attack may intensify and prolong the attack. However, if the patient is already on uric acid lowering therapy such as propenicid or allopurinol, which we're going to discuss in a minute, at the time of the acute attack, the drug should be continued at the dosage during the attack. But remember that the primary treatment of acute gout is using anti-inflammatory drugs. Furthermore, the control of high uric acid levels or hyperuricemia is generally not pursued after only one single attack of gout. If attacks are recurrent or there is evidence for tophaceous or renal disease is present, then we can start thinking about how to lower uric acid levels in plasma, and we will discuss those guidelines in a few. Now, non-steroidal anti-inflammatory drugs are the drugs of choice in most patients with acute gout who do not have an underlying health problem. Although indomethacin is the non-steroidal anti-inflammatory drug that has traditionally been chosen for acute gout, most of the other non-steroidal anti-inflammatory drugs such as naproxen can also be used as well. That's why the selection of the best non-steroidal anti-inflammatory drug should be based on patient's factors. Note here that you can also use cyclooxygenase 2 selective inhibitors. Those have shown success, but patients may require higher doses of these drugs in order to interfere with the inflammatory process associated with gout. To control the acute attack, non-steroidal anti-inflammatory drugs are prescribed at a full dose for 2 to 5 days. Once the acute attack is controlled, the dosage is reduced to approximately 1/2 to 1/4 of that amount. You have to taper the dosage over approximately 2 weeks. Gout symptoms should be absent for at least 2 days before you start to stop non-steroidal anti-inflammatory drug therapy. On the other hand, corticosteroids can also be given to patients with gout who cannot use non-steroidal anti-inflammatory drugs or colchicine. Steroids can definitely be given to patients with gout orally, intravenously, intramuscularly, or even intraarticularly, where corticosteroids are injected directly into the synovial space. Using parenteral corticosteroids confers no advantage unless the patient cannot take oral medications. One of those drugs that are frequently used for the treatment of gout is prednisone, which can be given at a dose of approximately 40 milligrams for 1 to 3 days, and that has been shown to have an effect in the treatment of acute gout flare-ups. Of course, intra-articular long-acting corticosteroids are very useful in patients with monoarticular flares, those patients who only have gout developing in one joint, to help to reduce the undesirable systemic effects of oral steroids. An alternative to corticosteroids would be the administration of ACTH. ACTH, as you know and will probably discuss further in the endocrine system, will induce the production of corticosteroids using the patient's own adrenal glands, although this treatment is not frequently used. Remember always that using a combination therapy of 2 or more of these options from the beginning is appropriate for an acute severe gout attack, particularly if the attack involves multiple large joints or is polyarticular. So let's talk a little bit more about the drug colchicine. As we mentioned, colchicine is one of the options that we can use for the treatment of acute gout. Colchicine is a plant alkaloid that is used for the treatment of acute gouty attacks. It is neither a uricosuric nor an analgesic agent, so it doesn't affect the levels of uric acid in the plasma. However, it does relieve pain associated with acute attacks of gout. And the reason why it reduces pain is that it has a potent anti-inflammatory processes. Now remember what happens during or after the deposition of urate crystals in the joints. As we mentioned before, that these urate crystals are recognized as foreign bodies by the immune system, and that results in the chemotaxis and migration of leukocytes, primarily neutrophils, from the plasma and surrounding tissue into the synovial space. And these phagocytes or leukocytes start engulfing urate crystals. Remember that that is associated with the release of many inflammatory mediators, including leukotrienes, that result in the induction of an intense inflammatory process that leads to the signs and symptoms of gout. After these leukocytes have engulfed urate crystals, with time, that accumulation of urate crystals inside the leukocytes will result in their rupture and leakage of the cellular components to the surroundings, including the degrading lysosomal enzymes, which result in causing damage to the surrounding tissue of the synovial space. So let's now take a look at how colchicine actually interferes with this process. Colchicine binds to tubulin and results in depolymerization of microtubules, which disrupts the ability of leukocytes to migrate. Remember that the process of leukocyte migration involves the formation of pseudopodia. Those pseudopodia are also very important to facilitate the ability of leukocytes to engulf foreign bodies. The formation of pseudopodia involves uh, reshaping of the cytoskeleton, primarily microtubules, which actually allow the cell to form pseudopodia and then engulf any foreign body. So colchicine interferes with the formation or the polymerization of microtubules by binding and interfering with the polymerization of tubulin. This means that colchicine impairs microtubule function, which impairs the ability of leukocytes to migrate to the site of injury and to form pseudopodia to engulf foreign bodies, and which are in this case uric acid crystals. And that definitely results in reduced inflammatory response. Although colchicine was once the treatment of choice for acute gout, it is now less commonly used than non-steroidal anti-inflammatory drugs because of its narrow therapeutic window and risk of toxicity. To be effective, colchicine therapy is ideally initiated within 36 hours of onset of the attack, and when used for acute gout in classic hourly dosing regimens, which are no longer recommended, when colchicine is given every hour. Colchicine causes adverse gastrointestinal effects, particularly diarrhea, vomiting, in more than 80% of patients. Dosing recommendations for colchicine in the treatment of gout have undergone modifications as awareness of its toxicity have been increased, and there are newer recommendations trend toward lowering the daily and cumulative doses of colchicines. In fact, in February 2008, the US Food and Drug Administration, the FDA, ruled that intravenous colchicine can no longer be produced or shipped in the United States because of its associated toxicity. And consequently, intravenous colchicine is no longer advocated for the treatment of acute gout in the United States. Finally, colchicine is administered orally. This is how it can be given to patients with gout and is rapidly absorbed from the gastrointestinal tract. Colchicine is known to recycle in the bile and is excreted unchanged in feces or urine. As we mentioned, there are several adverse effects or toxicities that can be associated with colchicine therapy. Colchicine may cause nausea, vomiting, abdominal pain, and diarrhea, and those are the most common or most frequently reported adverse effects. Chronic administration of colchicine may lead to myopathy, neutropenia, aplastic anemia, and alopecia. The drug should not be used during pregnancy, and it should be used with caution in patients with hepatic, renal, or cardiovascular disease. You will always need to adjust the dose of colchicine in patients taking CYP3A4 inhibitors, such as clarithromycin. For patients with severe renal impairment, the dose of colchicine must be reduced. Lastly, let's talk about Anakinra. Anakinra is a form of targeted anti-inflammatory therapy. It is an interleukin-1 receptor antagonist. Remember that the secretion of several interleukins can mediate the inflammatory process involved in gout, and interleukin-1 is one of those inflammatory mediators that result in further accumulation and migration of leukocytes at the affected joint. Anakinra was primarily developed for the treatment of rheumatoid arthritis, but can also be used for the treatment of gout. And it was shown that 90% of gout flares and a similar percentage of pseudogout flares respond to Anakinra. The pharmacology of Anakinra is very easy. It's a competitive inhibitor or antagonist for IL-1 beta, and it blocks or interferes with the binding of IL-1 beta to its receptor, and that's how it exerts its anti-inflammatory effect. So let's move on to discuss the management approaches of chronic gout. treatment of chronic gout aims at reducing the frequency or the number of acute gouty attacks and the resultant complications. And that is mainly achieved using urate-lowering therapy. Treatment strategies include the use of xanthine oxidase inhibitors to reduce the synthesis of uric acid, or the use of uricosuric drugs to increase the excretion of uric acid. Xanthine oxidase inhibitors such as allopurinol and febuxostat are the first-line urate-lowering agents, and that is why allopurinol is usually the drug that we use to treat gout chronically. In patients who cannot take allopurinol due to hypersensitivity or intolerance, those patients usually take an alternative xanthine oxidase inhibitor such as Febuxostat. On the other hand, patients who have a poor response to allopurinol can be given uricosuric agents such as propenicid, or they can be switched to a combination of propenicid and allopurinol. Remember when we said that acute gout results usually from fluctuations in uric acid levels in the plasma. And that means that there is a risk that the initiation of urate-lowering therapy can precipitate an acute gouty attack due to the rapid changes in serum urate concentrations. So there are several guidelines for when to initiate uric acid lowering therapy. Remember that we said that not all patients with hyperuricemia will develop gout. And that is why there are clear indications on when uric acid lowering therapies must be implemented. And those include the existence of tophus of tophi identified on clinical examination or through imaging studies in patients with signs and symptoms of gout, or in those who have a frequent of more than 2 years of acute gouty arthritis. Patients who have a history of chronic kidney disease can also be started on uric acid lowering therapy. And if there is a previous history of the formation of uric acid kidney stones. Let's start discussing the first drug, which is the first line for the treatment of elevated levels of uric acid levels in gout patients. The drug is allopurinol. Allopurinol is a xanthine oxidase inhibitor and a purine analog. Remember again that uric acid is the end product of purine metabolism, and it results from the conversion of xanthine and hypoxanthine into uric acid by the enzyme xanthine oxidase. So allopurinol prevents the metabolic conversion of xanthine to uric acid. That results in a significant reduction in the production of uric acid and lowering uric acid levels in the plasma. Allopurinol is an effective urate-lowering therapy in the treatment of gout and hyperuricemia, secondary to other conditions such as that associated with certain malignancies, where large amounts of purines are produced, particularly after chemotherapy or in patients with chronic renal disease. Allopurinol is completely absorbed after oral administration. The primary metabolite of allopurinol is called alloxanthine, which is also a xanthine oxidase inhibitor with a half-life of 15 to 18 hours. This means that allopurinol have a long duration of action because its own metabolite produced by hepatic metabolism can also inhibit xanthine oxidase. This means that effective inhibition of xanthine oxidase can be maintained with once daily dosage of allopurinol. The drug and its active metabolite are both excreted in both the feces and the urine. The dosage of allopurinol must be reduced if the creatinine clearance is less than 50 milliliters per minute. Of course, there are adverse effects associated with allopurinol, despite that it's a well-tolerated drug. And those side effects include hypersensitivity. And as we mentioned, patients with allopurinol allergy or hypersensitivity must be switched to an alternative xanthine oxidase inhibitor. And remember here that allopurinol can be given concurrently with drugs used for acute treatment of gout. And as I mentioned before, that if the patient was already on allopurinol therapy and develops an acute attack of gout, anti-inflammatory drugs can be initiated without needing to stop allopurinol therapy. Lastly, allopurinol interferes with the metabolism of 6-mercaptopurine. The immunosuppressant is azathioprine and thiophyllin, which requires a reduction in the dosage of these drugs if the patient was taking them concurrently with allopurinol. The other xanthine oxidase inhibitor is a drug called Febuxostat. Febuxostat is structurally unrelated to allopurinol. However, it has the same indications. In addition, the same drug interactions with 6-mercaptopurine, azathioprine, and thiophyllin also apply to Febuxostat. Again, here, the mechanism of action of Febuxostat is identical to that of allopurinol in that it inhibits the last step in purine metabolism catalyzed by the enzyme xanthine oxidase, and thus results in lowering of the levels of uric acid that is produced, and consequently reduces the levels of uric acid in the plasma. The adverse effect profile of Febuxostat is very similar to that of allopurinol, although the risk for rash and hypersensitivity reactions might be a little bit less. Febuxostat does not have the same degree of renal elimination as allopurinol and thus requires less adjustment in those with reduced renal function. Let's now move on to discuss some of the uricosuric agents. Uricosuric agents are a group of drugs that enhance the excretion of uric acid in the urine, resulting in lowering of plasma uric acid levels. Probenecid is the classical uricosuric drug. It is a weak organic acid that promotes renal clearance of uric acid by inhibiting the urate anion exchanger located in the proximal tubule. So after uric acid is filtered and present in the filtrate of the proximal tubule, some of it is reabsorbed back into the plasma, and that reabsorption is usually facilitated by transporters such as OAT4 and urate1. So probenecid is a powerful inhibitor of these exchange transporters, and that results in keeping uric acid that is filtered by the glomerulus in the urinary filtrate, and it increases the excretion of uric acid in the urine. In addition to that, probenecid at therapeutic doses can also interfere with the tubular secretion of several other drugs that are usually components of the beta-lactam antibiotics. Probenecid should be avoided if the creatinine clearance is less than 50 mL per minute. Now, pegloticase is a recombinant form of the enzyme urate oxidase or uricase. We mentioned before that uric acid is the byproduct of xanthine, and it's generated by the action of the enzyme xanthine oxidase. However, uric acid can also be converted to another metabolite called allantoin. Both allantoin and uric acid can both be excreted in the urine. So pegloticase is a recombinant form of the enzyme uricase that converts uric acid into allantoin. Giving that drug will enhance the metabolic conversion of uric acid into allantoin, which enhances its renal excretion. Remember here that allantoin is a non-toxic metabolite of uric acid and is easily excreted renally. Pegloticase is indicated for patients with gout who fail treatment with standard therapies such as xanthine oxidase inhibitors. It is administered as an intravenous infusion every 2 weeks. Lastly, Lesinurad is the first selective uric acid reabsorption inhibitor, or SURI, that is approved by the FDA. This drug acts by inhibiting the urate transporter urate 1. Remember, this transporter urate 1 is located in the proximal tubule, and it facilitates the reabsorption of uric acid into the plasma back again from the urine. It also inhibits the organic anion transporter 4, or OAT4, which is also associated with the diuretic-induced hyperuricemia. So it has a mechanism of action that is very similar to that of probenecid. The Lesinurad must be co-administered with a xanthine oxidase inhibitor such as Allopurinol, and is for hyperuricemia associated with gout in patients who have not achieved target serum uric levels with a xanthine oxidase inhibitor alone. So Lesinurad is one form of combination therapy that can be added to allopurinol when allopurinol is not enough to lower uric acid levels. Renal function should be assessed before initiating therapy and throughout treatment with Lesinurad. Do not initiate Lesinurad therapy if the renal clearance rate is less than 50 mils per minute, and discontinue if that persists at lower than 45 mil per minute.